With no further ado, I want to introduce another person requiring, fortunate for me, no introduction, and that's Bruce Maller. Bruce represents BSM Consulting as the founder and president of that fine organization. They are involved substantially with all of the educational programming we do at this event at the Academy with the support of the AAOE organization, and work very closely with Albert Castillo, our member services consultant, as well as the 16 courses that we do at Ascris in the spring now that are ASC track courses that we do in combination with ASOA, and particularly their education committee, which is led largely by our members, which is most helpful to that process. But I want to introduce to you Bruce Maller, who is the first person we turn to when it comes to questions of being on task with strategy. Bruce?
Thank you, Kent. I just need to know before I get started, Ralph, did you put Red Bull in Mike's water or something? Yeah. Tough act to follow, Romansky. That was good. Actually, Mike's comments leads into, in part, what I hope to accomplish over the next, actually, 30 minutes. However, after my comments, we'll have a little break. And then, as Kent mentioned, we have some panelists that are going to come up. And one thing that's great about working with Kent, he's very strategic about everything. But you really have to listen and think, because he puts these little breadcrumbs out there, and if you don't follow the trail with Kent, then you may not actually get to where he wants you to go. So my conversation with Kent about today has been going on for several months now, and Kent's vision for this afternoon, which Mike kind of kicked us off with, is to actually provide you some perspective so that we can kind of dig in and then figure out in this current world order strategically how we in fact do want to position ourselves. And the title that Kent assigned to me, that was one of the breadcrumbs, was positioning, not quite get the words right, take advantage of opportunities of change, something to that effect. That wasn't my words, that was his. But it's insightful because there are so many changes that are taking place around us. And so what we're trying to do through my comments and then the panel is to actually bring you some clarity. So I'm going to start kind of at a little bit broader, maybe 10,000-foot level, and then we're going to take my comments and they will become the context for our 4 centers. So we'll be able to kind of dig in and learn as to how these environmental changes are actually impacting our centers. And we have a nice cross-section, a nice mix of centers with somewhat different business models. So at Kent's opening, he mentioned SWOT. Anybody pick up on that? Yeah. So SWOT is an instrument. It's a tool. It's a tool that is used as part of an overarching strategic planning initiative or process. And it's a very useful tool. He's going to be incorporating that, and in the SWOT, he's going to be gathering some information from each of you about your strengths and weaknesses and where you see opportunities and threats. It's the same exact instrument we use in our organization. And it is a vehicle we use to help us focus. And it's really quite helpful. But I want to make one point, which I may reinforce later, if I remember. But the point is that in my work over 30-plus years, working with many different practices and many different centers, people are often asking me for the secret sauce. What is it? You must know, Bruce, what is the one thing we need to do differently or better? And frankly, that has caused me over time to do a fair amount of reflection. And I've been able to kind of encapsulate what I think are really some of the best practices, because the success in different practices and centers, you quickly learn, is never accidental, but it's generally purposeful. And those that are most successful are the most purposeful. But I have been able to kind of distill down to probably around 5-ish. I'm going to focus on a couple, and they're the ones that I think are most relevant to our discussion today. Yes, our great practices and centers focus on their people and invest heavily in their people. Yes, they focus on the patient's experience, and they build systems around making sure that they're doing a great job for each and every patient. Yes, they're fiscally disciplined. They do a great job in managing the business affairs of their practices. But the two that are maybe the most under-recognized, but nuanced, and to me the most important are, one, our best performing practices and centers are disciplined, and they're disciplined about planning. Planning is just part of the routine of what they do. And I'm the first to admit it's hard. And what's the number one reason it's hard? Time. I'm just like all of you. I don't have the time, but I make the time. And our best performers also follow that mantra. You have to set aside the time to actually engage in this process. We do it fairly formally at BSM, and that process helps direct us. So everything we do is purposeful. We don't tend to be very reactive to anything. That's not to say that I'm not opportunistic. I am opportunistic, but I do it in a very strategic way. But it has to become a staple. So that is one of the best practices, if I really stop and think about it. And it doesn't have to be that formal, but you need to be conscious about it. And to me, that's one. The second, your planning won't be successful. And by the way, it's easy to come up with ideas, but what's the hard part? Execution. And where the rubber meets the road between our average to better and our best is execution. Execution. The ability to focus, to be able to rally a team, build a team that is truly committed to those initiatives, those imperatives that I saw Kent use that language in the overview for today. Strategic imperatives, the must-haves, the ability to rally your team and organization, that requires leadership. And I've talked to this audience in the past about that. But it isn't just you being better, more emotionally intelligent, a more effective leader. The real secret sauce to leadership, this is, to me, the best practice that I've seen and observed in my entire career. It's when you have strong physician leadership coupled with strong administrative leadership. I'm not done. And when the administrative and physician leadership are conjoined. A single vision, single mission, they're clear on their why, and they're outstanding at their what and their how. But when they are aligned, magic happens. Without that, it's not to say you won't achieve good outcomes, either clinically or financially. But if you want to become the best of the best in any business or profession, you figure that out fairly quickly. Okay, let me do some picture painting. Kent asked me actually to use slides today, which, as he knows, is really hard for me to do, but I'm going to try. How do you use this thing, Kent? Oh, just kidding. But he actually wanted me to give you some data, some statistics, some information. And so I'm going to kind of paint that picture for you. And I believe if you just think about what I'm going to share with you from a strategic standpoint, what I'm going to fill in on your SWOT analysis is a clear picture of the environment. That going on around you, that's orbiting around you. This is a difficult and challenging time because there are so many events going on and they're confluing. And for me, that spells opportunity, but only if I'm clear on how these changes are impacting my market. Healthcare still, 30 years later and 30 years from now, happens at the local level. And you've got to get this. So some of the things I share with you, you may look at it and go, whatever, Maller. It doesn't apply to us. Some of the things, though, I think are quite relevant. So I'm just going to walk you through a few things, and I'm going to focus on a few global factors that I think are really important. I'm not going to share anything with you that I really don't think is relevant to ophthalmology. Growth and expansion of Medicaid, growth in Part C, the activity with ACOs, and then other stuff that's going on in your markets that is real. There is not a meeting that I have at this conference where someone does not bring up with me, oh, there's an ACO in our community and they're buying up this or they're doing this or there's a health system buying surgeries. There's not a meeting where I'm not hearing of some consolidation activity taking place that I believe is relevant. So I'm going to spend a little bit of time on consolidation, both in terms of the payer side and the provider side. And then lastly, I want to just drop something into the conversation because there's a little bit of a buzz in the community going on about financial guys that are actually out there in the hallways. Maybe some of them have leaked into the room that are kind of like interested in this specialty. They're really interested. The money guys are kind of here again. They were here 20 years ago and left. We didn't treat them very well, according to them. I thought they didn't treat us very well, but whatever. They're back. And we're hearing of transactions being done, and you're going to hear private equity. If you'll hear it once, you'll hear it 10 times. They're here. And I actually don't view that necessarily as a bad thing. So I'm going to give you a little bit of my view on how I see that. So let's start off with what's going on, big picture, and this stuff is significant. So let's just start off on the Medicaid expansion side. And for many of you, this might be a whatever. Work with me here. Work with me. There is a strategy here that is extremely relevant, and it will tie to my payer consolidation discussion here in a few minutes. So we all know what happened under the Affordable Care Act, how we're going to solve some of the uninsured issues. We're going to bring more people into the assured roles by raising the income threshold, and voila, we're going to have more people now eligible for insurance that were heretofore uninsured. And this is the vehicle we're going to use to do that. It's called Medicaid expansion. But not everybody decided, as you know, at the state level to play in Medicaid expansion. I'll show you that in a moment. Well, that's easy for you to say, feds, but it ends up on our budget. So states look at this and go, this is more than a whatever. This is a big line item. And the Fed said, don't worry about it. We'll subsidize this for a little while. But when that bloom is off the rose and they actually have to pay for this, states are going to be facing 2020, 21, 22 substantial budget deficits because at that point in time, the federal subsidy that we agreed to in the Affordable Care Act will begin to reduce, and it will have a significant impact on states. But the bottom line is there are new lives coming through the channel. The blue are those states that are participating in Medicaid expansion, and the orange are not, and the light blue contemplating. So 31, including the District of Columbia, that are playing in the expansion. Here's just a sampling of the impact, and it is dramatic. It's dramatic, and we'll get to where the lives are going in a moment. So I just took a little snapshot of 5 states. You can see pre and post and the percent change. Here are the top 5 states with percent change. So you can see pre, post, and what the significant percentage increase in enrollment. Where do these lives end up? Managed care. So by virtue of this, the states said, well, we don't want to handle these under Medicaid fee-for-service. We'll be crushed and punished. We don't have infrastructure. We don't want to manage this. So why don't we just simply subcontract these lives to managed care? So we're putting more lives into the hands of fewer. So I'm going to give you just a quick case study. In the state of New Mexico, for example, not only did you can see here in the state of New Mexico what's happening in terms of covered lives in Medicaid. The state sent out an RFP, a request for proposal, and indicated that they were going to take the number of managed care plans that had contracts with the state for Medicaid from 7 to 4. So not only are we going to increase the number of covered lives, but we're going to concentrate those in 4 third-party payers. Now, I represent a large practice in that state that saw that change as an opportunity. That change as an opportunity to actually go collaborate with those plans and offer a solution that would be mutually beneficial. And I've spoken about this in the past. Historically, we have viewed payers as our adversary, and I get that. I understand that. It's zero sum. We're at odds. There's a budget. They want what you want, or they want to reduce your fees. I get it. But in the New World Order, we need to think differently. We need to think about how we can possibly collaborate with them. We have to view them as, in many ways, a customer. But that is a real-life case study of what is happening as a result of Medicaid expansion. Let's move to Medicare. So this is an interesting chart that plots the growth in Medicare Part C, or what we call Medicare Advantage. And you can see from back here in the 99 timeframe, we're on a pretty nice trajectory. And by the way, that's 16.1 million in the numerator of the equation. The denominator would say be the total number of Medicare lives. And you can see I just did the math for you down here. There's about 30% or so of the total Medicare eligible lives that are sitting in Part C, and that trajectory is going in a forward increasing direction. And by the way, that 16 million does not include the Medicare lives that have been dropped into the Medicare-sponsored accountable care organizations. It does not include those numbers. So if you add those numbers to the 16.1 million, you're now approaching nearly 45 to 50% of total Medicare lives that are in managed care. And that's what this picture depicts for you. So the yellow is, and you just follow the little legend here. So those of you with 40% or more in Medicare Advantage, you can see where you are. The yellow states are 30 to 39%. So if you're sitting in Montana or a state where the penetration is less than 10%, that's one of your whatever, Mallory, I don't get it, it's not a big deal, we're on fee-for-service, all is great with us. True. So in a state like that where I do my environmental assessment, I may be less concerned about that particular factor. ACOs. So ACOs are real, they're happening, accountable care organizations, and there are now nearly over 700, approaching 800 accountable care organizations, of which about 300 to 400 have been enabled by CMS and have been set up under the CMS program that was part of the Affordable Care Act. So you say to yourself, well, what are those others? Those others have been set up on the commercial side by health systems, by hospitals, by physicians, who have elected not to play by CMS rules, but are anxious to create something that they think is a vehicle. So again, ACOs are a vehicle. They're a vehicle to gather share and deliver care. Gather market share and deliver care. And they're an important trend. And even in a small community, where there may not be much Part C penetration or even Medicaid expansion necessarily, ACOs can wield a fair amount of market power. We're going to hear that from some of our panelists here in about 20 minutes. So it's important just to be aware of what's going on. And there's lives that are actually being contracted for and are being managed through these accountable care organizations. With CMS, if you follow the house rules with CMS, set up your ACO using those rules, they put a certain number of lives, CMS did, and they just dropped them into that ACO. Now, those patients who've been dropped into that ACO, by the way, were not given notice of that. They got a letter to say, oh, by the way, you're now a part of that ACO. You say, well, how did I get there? Well, first of all, there was an ACO in the community, and we looked at who was providing the predominance of your primary care. And if that primary care provider was part of the ACO, you got assigned to the ACO, whether you like it or not. But the good news is the patient can opt out. In that CMS model, the patient can opt out and they can actually go see a doctor that's not in the ACO and that doctor can still be paid fee for service. But we have to think about what's going on because over time, these ACOs actually are going to control share, and you need to understand how to interface with them. And that's a little picture. I'm going to drop over and get to this piece here. Market consolidation. So we are aware, of course, all of us in the room, that there are driving factors to why there's lots of consolidation, both in pharma, payer, provider side. Truth of the matter is, capital's cheap. As long as interest rates are low, it fuels capital investment, and that's a key driver in this. But it's more than just the availability of money. It's because all of you, from payers, providers, pharma, are being forced to figure out how to become, quote-unquote, more efficient. And that means wringing cost out of the system. So if we consolidate, we can eliminate G&A, general and administrative overhead, reduce our cost per unit, cost per patient, and you need to be thinking that way. You know and should know what your costs are today to treat a patient in your ASC, and you're always now thinking about how can I bring down my costs per case. And in your business, it turns out to be that volume's a key driver that helps you overall manage your fixed overhead more effectively. So those elements become key drivers as people think about trying to manage down costs. The third one, and I'm going to use a term that I would challenge you to think about, which is relevance. You need to think about how you become more relevant in the current world order. And so in some cases, size is needed to be able to come to the table so that you can be seen as relevant by those people you're trying to partner or align with. And this is what's different this time around. There is legislation that actually was the gas on the fire that has really driven a lot of this activity. And in the last 2 to 4 years, the pace and rate of change is like nothing I have seen in my 30-year-plus career. Now, it's a little nuanced, but it's happening, and you can feel it. It's palpable. And I feel it because you tell me. You tell me exactly what's going on, and you're going to hear some of that from our panelists. So we know what's going on with the big three now. Let me put the big three in perspective. So assuming, again, we have United Healthcare sitting out here with 42 million covered lives. Percentage is, by the way, the percentage of this total. But let's just focus on this for a moment. 133 million. What would be the denominator? 310, 320 million total population. Take out of that total population uninsured, 40 million. Take out of that equation 35 to 40 million of Medicare Part B, fee for service. So your N now just went down to 230 million. You talk about market consolidation. Oh my. You add the Blues and Kaiser to that, and now all of a sudden you see how consolidation can have a significant effect while you're driving more lives into managed care. And as the payer market is consolidating, it's a little bit of a wake-up call to say, okay, got it, Maller, but in our community, now you need to understand what is going on in Atlanta, Tallahassee, wherever, Las Vegas. Because within each market, it is unique and it's different. So from a big picture, this is great to know, but my goal is to motivate you to go and get that same data for your market so you understand that dynamic. Because it will shape your strategic decision-making. It'll shape and should shape who you partner with. If you sell, do you sell, to whom? There's all kinds of considerations that you need to think about. But ultimately, it'll come back to the vision, or what I call your why. And the vision for many of you is you're very independent people. You want to hold on to that ability to maintain a private practice. And what Mike described for you is a very important strategic contextual issue. And that is one of the greatest strengths and assets that you have is your surgery center. But not unless you leverage your surgery center in the most effective way. It is a strategic asset. And that's why listening to Mike today, my key takeaway from Mike was our future is actually very bright. And it is only bright because we have people representing you in Washington that are actually focused on just your surgery center. And that is pretty cool. So to me, for all of you in this room, that is one of the best strategic assets that you have, but if you don't use it effectively, shame on you, okay? So it's also going on in other places, on the provider side, in particular with hospitals. And of course, we all know at hospitals, especially those with accountable care organizations, are trying to figure out what to do with specialists. They don't need to own you, but they need to have a relationship with you, and you need to be back at that table participating in that process. You are an asset to them. You are part of the product they're trying to deliver. Part of the product they're trying to deliver. You just need to make sure that that product does all the things that they need in terms of measurement and utilization management and quality assurance, because that's what they need in order to represent themselves, perhaps with third parties. Lots of stuff going on the provider side. I could spend an hour just discussing what's happening in ophthalmology. I could sit here and spend a lot of time with all the derivative integration and whatever models, from networks to just simply, strict acquisitions to mergers. And in the last 12 months, I just measure that. My staff is in the room. We measure it by the number and type of inquiries we get into our firm. And probably 80 to 90% of those inquiries are all about combinations, business combinations. People are trying to figure out who do they align with, so there's a lot of that activity that's taking place, which leads to the last part. The role of private equity, the role of financial partners. They're here, and they're not going to go away anytime soon, but I actually don't see them as a problem. I actually see them as validating. They believe in independent private practice. They believe that what you guys have is a tremendous asset. They look at our community of ophthalmology and see a bull market where the rest of us are too close to it. We're way too close to this. We're way too myopic about the view of our specialty. Others who are bright and smart actually see this as a specialty with enormous upside. So how do they, or what's going on now? There's a handful of practices that have, quote unquote, sold to private equity firms. And by the way, I want you to think of the words private and equity. They're investing private money, equity meaning ownership, and they make investments to acquire. And they do it through various vehicles. And they serve a useful purpose. But it only makes sense if it fits strategically for your center and or for your practices. But they're here, and they're interested for the reasons I've stated. They can bring value, and I'll touch on that in a moment. Should this be on our radar screen? It depends. Depends on your vision, where you are in your life and career, what your succession plan is, what your growth plan is, what your growth strategy is. I can assure you they're not interested if you don't have a growth plan. They are not interested if you don't have scale. They're not interested if you're not committed to actually building a business. But they can help in different areas, and this is what I've seen so far in the transactions I've observed. Succession support. We have a big generation of folks transitioning over the next 5 to 10 years. A lot of our entrepreneurs, a lot of our big founders, a lot of the folks that Mike and I have grown up with in the ophthalmic ASC. And those people are looking for a means and an exit. That doesn't mean the practice is going away. It just needs to be done thoughtfully, and they can play a role in that. Strengthening and scaling, because what you find oftentimes in our practices and surgery centers is they don't have the infrastructure. They don't have the quality of people necessarily to build and establish that platform, so they can be very helpful in bringing talent. They can help also with us acting better, strengthening our governance in terms of how we make decisions. And in the end, for the model to work, there's got to be incentives that are aligned between your investor, partner, and of course the physicians. It can't just be, I sell and I'm gone. It has to actually be a partnership if it's done correctly. But if it is that you do have a growth plan and you want to expand, build, grow, acquire, what have you, capital is a key element. So just wrapping this part of the talk, and I'll kind of give you a little bit more perspective as we wrap the session at the end of the day. There are lots of cross currents, and you can get caught up in that. I loved Mike's description of the in-office cataract surgery. I saw it and I felt it too. The first 10 minutes was a lot of, right? It was just like, for guys like Mike and I were like, okay, now that we have that out of the way, can we focus on the real issues? So there's a lot of that activity going on that I feel right now. The cross currents create confusion. And my job with all of you is clarity. One of our key attributes of strong leaders is they have that ability to bring clarity. It doesn't do you any good when you go back and you further confuse things with your partners. Your job is to say, you know what, lots of things going on. We need to get educated, and once educated, we will figure it out. And that's how you have to, and I've seen that over time. You are really the most resourceful group of people that I know. But alignment is important, and the focus on alignment is always access. You have to think about access channels and how would we strategically align with whomever to strengthen those channels. And as I mentioned earlier, it's discipline. It's discipline and that ability to focus, but embrace it. It's actually, to me, it's the fun part of what we do. The fun part of what we do. And this group, why I love this particular group at OOSS is because you're forward-thinking, you're entrepreneurial, and you actually say, okay, I got it, and you guys go make it happen. And we've seen that, of course, repeatedly. So we are going to take a little break here, about 7 minutes. You told me 7 in your email this morning. I did read that part.
Exactly.
7-minute stretch break. When we come back, I will introduce the panel, and then we're going to get into kind of the tactical execution, and you're going to hear about these different business models that I think will tie a lot of our pieces together. As we organized the panel, we were deliberate about the who to make sure that we got a good cross-section of business models and also a good cross-section geographically. And so just the format for what we'll do, I'll introduce each of the panelists. They'll provide a 2 to 4 minute synopsis of their business, so you have a sense of where they're coming from and what and how their surgery center is organized. They'll also give you a little bit of an environmental view of what's going on around them, which I think is very important context. I may, kind of probe them a little bit if I'd like them to go a little deeper, explain something with a little bit more color. I'll have a few questions here and there, but truthfully, what we'd like is for you all to participate in this discussion. And I think you'll find this to be a very useful, very helpful conversation. So I'm going to kick things off by introducing Stephanie Harvey and Tom Harvey, and from Chippewa? Chippewa Falls, thank you. Independent Surgery Center is the name of their facility, and Steph will kick things off and give you a little bit of that background, and then Tom's going to fill you in a little bit on their environment and how things and what's going on in their community. Steph?
Thank you. We are a small surgery center, 1 OR. It's called Independent Surgery Center, located in the Chippewa Valley of Wisconsin, which is about an hour east of Minneapolis, St. Paul. We incorporated 5 years ago and started doing surgery about 4 years ago. And the surgery center was put together by 2 physicians, Dr. Harvey being one of them, and another physician from 2 competing clinics. So they are now partners in a surgery center. Not all of the physicians from each of their clinics actually operate at the surgery center, so we have a very unique environment. Over the course of the last 4 years, we have now grown so that we do 33% of all the surgeries, all the cataract surgeries in the Chippewa Valley. The other 65% or so are done at hospitals because there are no other surgery centers except for one that does about 5 cataract surgeries a month. So we are the only ophthalmic surgery center in the area. We have a very unique situation in that we have a physician-owned hospital right down the street. So there aren't very many surgery centers being opened up because of obviously the reimbursements for an HOPD versus a surgery center. So you don't see a lot of doctors jumping out at that ownership to open up a surgery center where they're going to be paid a lot less. And then I think Tom's going to talk about our environment.
Yeah, Bruce, we've got a great environment. Has anybody been to Eau Claire, that area? I mean, okay, so Chippewa Falls, where our surgery center is, that's where Leinenkugel beer is made. So in Wisconsin, we embrace that as well as cheese, and it's a great environment.
Love it.
Thank you. No, seriously, we have a great place to practice medicine. We have the benefit of a strong, independent physician network to counteract what is a change that you nicely outlined in your talk with some very big players in the system market. And they have so 2 major systems with another probably 2 interested in entering into our region. But honestly, the independent doctors have really claimed a stake, especially in the surgical subspecialties. Being an eye-only surgery center, we have really distinguished ourselves as being the go-to place based on quality nursing staff. Believe it or not, people love the fact that our nurses know eyes, and that's what they do. Having the top technology, and finally, the best price. And we say we're half price. You want to go to the hospital, be my guest. You're going to pay double. Let's not forget what the impact of anesthesia is. Anesthesia can be billing quite a bit, and that will ultimately affect how the patient can decide to upgrade implants or some other new technology that may be a future or present revenue stream depending on what you have in your centers. So we have a great thing going, and it's from scratch, but I want to give credit to our CEO. She's really been instrumental in making that happen.
A heck of a CEO, right, Tom?
She is, in fact. Great boss, too.
Tom, do either of those health systems sell their own insurance product?
They do, in fact, yeah. So there is, in fact, interestingly, our clinic uses their insurance product for the health insurance in our. So it's very incestuous and confusing. However, when they come into our center, and I want to credit Stephanie for having these contracting contacts. They come in and see what we do and the care that's delivered in the fashion that the patients want. They are top tiering us every time. On the other side, they are realizing that they would probably be more profitable if they took all the eyes out of their HOPD paid surgery center and had us do them. They'd end up ahead. They're losing money on eyes.
Yeah, on the plan side, they would reduce their cost dramatically, but they are conflicted, which creates all kinds of, because the management of the plan side in the health system versus the operating side, they're different people with different budgets, and they're in conflict, which makes it interesting and challenging. Thank you. Bob Nelson is the executive director of the Island Eye Surgery Center in Nassau County in New York on Long Island. And completely different model than what we just heard from Steph and Tom. So, Bob, could you give us a little lay of the land?
I can do that. Actually, I don't know about my other panelists here, but I don't consider myself to be an expert at anything. Literally, nothing. But I surround myself with really smart people, and that helps me do my job. But from a perspective, a matter of perspective, my perspective actually is as a surgical PA for 38 years, all but 3 of those years have been in surgical practices, private surgical practices, that had an outpatient facility. Either back in the day when they had a single OR in a plastic surgery center that wasn't licensed and before there was any legislation in New York State, to where we are today in our 3 OR facility. So it's a matter of perspective. My history in ophthalmology is 25 years in ophthalmology and 15 years now at Island Eye Surgery Center. So I'm grateful to OOSS. I'm grateful to the ASC Association for the direction that they give me in allowing me to do my job. Island Eye actually was founded in 1999. We did our first full year of cases in the year 2000, and there were 8 founding partners at that time. The 8 founding partners in 1999 had this wild dream that at some point in time we would do 7,000 surgical procedures in our surgery center. Well, 2005 came and went, and 7,000 cases came and went in that short period of time, and we very quickly began to realize that we had a good model. Certainly, we had a good product that we were offering to the community of doctors that had heretofore practiced in the hospital. And we're in a situation now where this year, 2015, we will do nearly 14,000 procedures in our facility. It's a 3 OR facility. It was originally a 6,000 square foot facility. It is now 9,000 square feet. We've added some additional space, but we are in the process right now of developing a new surgery center. As far as the market goes, we are about 25 miles outside of downtown New York City. The population on Long Island, the 3 counties that we actually draw from, is about 5 million people. From a density of population perspective, we have about 4,000 people per square mile in our communities. So we're drawing from a very densely populated area. As far as the market goes with health payers and health systems, there are several health systems certainly on the island. One predominant healthcare system, I'm sure that's not too dissimilar from most other markets. But what we've seen recently is we've seen the migration of health systems from New York City, predominantly Mount Sinai and NYU, make an appearance on Long Island. They're buying up practices, they're buying up specialty practices, and indeed they're buying surgery centers. That's the lay of the land.
How about from an ophthalmic surgery center standpoint? Are there several? I know New York has CON restrictions.
Yeah, we are a CON facility. On Long Island, there are probably 3 or 4 ophthalmic-specific surgery centers, and in the region, certainly many more than that.
And have you seen or observed any acquisition of ophthalmic surgery centers?
Yes, there have been 2 acquisitions or mergers recently on Long Island with that predominant healthcare system that bore a controlling interest in those 2 centers.
So it's North Shore Long Island Jewish Health System is that kind of dominant system, and they also recently introduced, Tom, similar to you, they've introduced their own insurance product. Right. So here they are they're contracting with third-party plans, and they're competing with them at the same time. They have an ACO. They're buying up specialty practices. They're buying up surgery centers. And you say, well, why are they doing that? They're aggregating the elements of a delivery system, and one in which they can most effectively control cost and deliver quality.
And they bought up, Bruce, many, many hospitals in the region. Many hospitals.
So that is an interesting perspective. We're going to kind of travel across the country 3,000 miles now to Newport Beach, California, and have Dr. Lee Novak. Lee is the managing partner, Lee, of the Newport Bay Surgery Center. And a similar model in some ways to Bob in that they've got a number. Bob, how many owners were there in your Island Eye Surgery Center?
The founding ownership was 8 owners. We have 13 owners right now.
13. How many credentialed surgeons?
38 surgeons on staff.
Okay. And I suspect 25, 38 minus 13, who might want to be owners, but that has its own set of challenges. But Lee, if you could just give us an overview of Newport Bay Surgery Center, that would be great.
Sure, and thanks for putting this on. I love the 2 talks already. They were terrific. So
thank you.
I found myself nodding way too much. Not nodding off, yeah. Nodding this way, yeah.
That's okay.
Yeah.
I wouldn't have said anything.
Yeah. So our surgery center started about 8 years ago. We started with 9 individual physicians with 7 different practices. We're in coastal Orange County. It's a beautiful area. It's very competitive. There's lots of ophthalmology and ophthalmologists. And we all have reasonably good practices and reasonably sized practices, and we all found ourselves just scattered. So we were able to put together a real incredible core of people that work together surprisingly well. We grew our center. We started with a 3 OR center. We've now added a femto into our OR. Our practice is now 17 ophthalmologists representing 15 practices. Wow. So we've grown, and we've captured quite a large section of the cataract care in Orange County. We've done a lot of responding to kind of our environment, because what's interesting is a lot of what you guys are saying is we're seeing it in Orange County. There's a lot of consolidation. So in Southern California, what we have is, in our area, we have 3 main hospital systems. We have one called Hoag, one called St. Joe's, and that's with Hoag, sorry. One called Memorial Care, and then Kaiser, and then we have the UC system. And over the last 2 or 3 years, 2 of the systems, Hoag and Memorial Care, have gone to war completely. And so the physicians, we all take patients in both of the hospital systems, so we were sort of stuck in the middle. And so we were really forced to decide which course we were going to take. We were going to try to be Switzerland, or we're going to pick a side, how we as a group going to work this. And it turns out that after much deliberation, we ended up picking a system. And we let them buy in 20%, which was an interesting move at the time. And it's actually paid off well because they want to come back. They've come back and want to buy more. So that decision was based on many, many factors in terms of how the hospital system treated their physicians, that sort of thing. So not to get too deep into the weeds, but we have this incredible dynamic now that we're facing.
But in the end, the physicians made that decision. What were the 1 or 2 things that really drove them to decide to do a transaction? Because, of course, you've got a competing system, and if I heard you correctly, many of your 17 doctors are working with the 2 systems, yeah?
Absolutely, and it was actually a lot of contracting issues, a lot of hard choices, but ultimately we felt that we needed to pick a system. We needed to, we couldn't just be floating out there because decisions would be made without us. And so by kind of going to the hospital system we picked, we presented kind of our solution for ophthalmic care in our community, and they are buying it so far. So we've been working with them to create a larger eye institute, for instance. I mean, kind of big, broader things that wouldn't have ever happened had we not gone down this road.
Flipping my first question, Lee, what would you say their motivation was? Because a 20% interest in an ophthalmic surgery center for a big health system feels like a bit of a nit, right? It's just not a big deal to them in the grand scheme of things. But they must have had something in mind strategically.
Absolutely, and it's hard to say exactly what that was, but I'm sure there's a whole host of factors. But they're interested in kind of what your model is seeing. They're trying to create their own health plans. So the system that we joined is interested in creating a health plan that will run through their system. And we were able to convince them that if they were going to do this, ophthalmic care moving forward was critical. Because if you're going to take care of a community, you're going to have to take care of their eyes. And even though you've forgotten about us for 30 years, if this is your strategic plan, then you need to have us as your partner. And they believed it, and they still believe it.
Well, and if the product is, for example, going back to my earlier comments, say a Part C product, a Medicare Part C product, ophthalmology is exceedingly relevant to them financially. The cost per member per month in a typical commercial under age 65 population from the health plan's perspective might be $3, $4, $5 per member per month. You go to a senior population, it could be $25 to $30 per member per month, assuming that your relationships are all unmanaged and fee-for-service. If you can find a partner to align with that is willing to work with you to share risk and reward, whether some case rate or a bundled payment or some type of capitation arrangement, they actually, from a health plan side, can look at this 20% ownership as the ability for them to control an important cost in a Part C plan. Does that make sense? So I get why they were there. Does that resonate?
Absolutely. And there's another factor, though, and the other factor is that there's a coalescing of surgery centers in our area, not just ophthalmic. We're a single specialty center, which is unique for our area. But there are several other centers that are, there's a GI center, there's a multi-specialty center that the hospital is also interested in partnering with. So they have a larger surgery center strategy of which they want us to be a part of, and that's why they're coming back asking us to buy more, because at 20% we really don't want to be a part of it.
So you end up with a little bit of leverage, interestingly enough, in these discussions and negotiations when you have an asset that they value.
Yes.
And that's a great teaching point, Lee. there are other examples very similar to that I'm aware of, where major health systems, not just in California, I'm aware of some in Northern California as well, where Kaiser, the largest health system in Northern California, has also bought minority ownership shares in ophthalmic surgery centers. And I've thought to myself over the years, again, why? What was their motivation? Why were they interested? And we're hearing real life, and I think that's a great case, and I think we're going to hear more of those kinds of relationships as we go forward. We're going to go back across the states we're going back 3,000 miles. And Dr. Maria Scott, Chesapeake Eye Care and Laser Center. Dr. Scott also owns and operates a surgery center, and again, slightly different model, maybe closer to Tom and Steph's, but she'll give us kind of the view from the Chesapeake Bay.
Thanks, Bruce. Good afternoon. We are in Annapolis, Maryland, beautiful Annapolis, Maryland, and I own Chesapeake Eye Care and Laser Center. We opened that in 2001, and then we're fortunate enough in 2002 to open up our surgery center. Very unique in that we're on the campus of the local hospital in one of their physician office buildings. And I don't know if I'm the only one in the country that could say that, but I think it's pretty unique.
The population is dwindling.
Yes.
So.
And it happened because the hospital was going to partner with us back in 2002 and with a large retinal practice as well. The retina practice decided that it was too risky to partner with one doc, and so when he pulled out, the hospital said, we can't partner with just one ophthalmologist, but they felt so badly they said you could still do the center, which was fabulous for us. So, thanks to Jeff Eckert, thank you very much, and his planning, we were able to put our surgery center together right on campus, and we're an exclusion state, which means that you can have a one-room surgery center. And then in 2006, we went back, and ahead of time, we asked the hospital to do that. And in our first lease, we were smart enough, luckily, to say that we could expand to 2 rooms, because when we were operating in the hospital, we were operating out of 2 rooms. Our exclusion is that it has to be ophthalmology only. And right now, it is just the partners in the practice that operate there. So we're a 6MD, 2OD practice. The surgery center is right next door to the practice. 3 of us operate there, the oculoplastic surgeon, I have a cataract glaucoma specialist, and then me. I'm 85% owner in the practice, or in the surgery center side of it. We have a great relationship with the hospital. I'm on the board of the foundation in the hospital. They have an ACO, so that's one of the things that we're looking at and considering. In terms of our market, we also have an equity partner that has bought out a very large practice in Baltimore, and they're trying to expand as well. And we have an optometric practice that has been buying many centers. They have 60 to 80 in our area, but 250 across the United States. So the question is, will it be kind of an upside down where they'll be making the rules for us, and we're going to have to go to them and ask to do their surgery?
It's interesting, the optometric piece, which has not gotten really any coverage today. Optometry, of course, they are going through a similar exercise in terms of trying to figure out how all of these changes is going to impact that specialty. And we're hearing more and more of what Maria is describing, which is they're very rapidly in many markets trying to aggregate share through either an acquisition model, franchise model, network model. You're hearing all kinds of derivative forms of OD models, and their goal, control share, hire surgeons, build surgery centers, hire surgeons that work for them, is a stated goal for many of those groups or networks. Many of them are folks that you currently co-manage with. So it's going to be interesting how those paths kind of cross and align over time. Now there are, frankly, just if you take a step back and you think about this from the standpoint of the payer, just digress for a moment. If you look at it from the standpoint of the payer that has a population of seniors or commercial lives that they're responsible for providing service for, and you think of what do they want and what do they need, it actually lends itself to a broader conversation about eye care, which is a continuum which addresses their needs in one-stop shop, which is the ability for you to actually, A, take risk with us, and B, cover the complete continuum of care from routine to hardware to primary eye care all the way to the facility. By the way, is Albert in the room? Where is he, Kent? Is he hiding from me? Albert Castillo, if he were in the room, is he not here, Kent? He's hiding, okay. But if Albert were in the room, I'd pick on him right now, because I think it's extremely important for you to be educated about what Albert's team has done in a very challenging market in San Antonio, where they have built something like this, involving elements of surgery center, disparate, different clinical ophthalmic practices, and created a network, and they've proactively gone to plans for years and years and years, and have become really a true strategic partner of many of the payers' side in their market, and have done a very, very good job of controlling share. That's really forward-thinking and perhaps would be challenging, but I think it's important that we not lose sight, and I appreciate the optometric piece, because it's going on in most markets. So it's a very important data point. So this time is your time. I'll sprinkle a few questions in, and I'll kick things off, but do you have microphones, by the way, Kent, handy? You've got one? All right. One. You have your running shoes on? I do. All right, good. Please, any questions from the audience? Yes, sir. Okay, we'll start over here, and then we'll have Kent run back across the room.
In terms of putting together resources for what we're doing, in terms of providing care to people, one of the big shortages that's coming up that you haven't addressed yet is that of physicians. So there's all kinds of other people with lots of leverage, and certainly everybody wants leverage over physicians. And obviously this is a strange group of people. This is not the usual audience. But how do you see that factor playing into what's going to happen 5, 10, 15, 20 years down the road as the baby boomers really hit?
Yeah, I'd love to get input from our panel to just take a quick stab at that. Remember, I used the term relevance earlier, and contextually, as things are changing and the demand for eye care disease is greater, we're going to have to be a lot smarter about the way we integrate and the way we work together. So to me, if I look at our panelists and think of your question within the context of their business models, we're getting the surgery center side of their business model, but there's the practice side, because it's got to somehow, you got to crack all those combinations, which is where, for example, optometry does play an important role. I suspect every one of the practices probably has some relationship with optometry. So what I want to hear, what I want to hear as a payer is a sustainable model 5, 10 years from now for delivering eye care that meets the needs that have been articulated up here. So I think you need to be a lot more strategic and thoughtful about how you do that. Because of the fact that we have fewer ophthalmologists, that just says to me as a business person, we need to learn to use you to the highest possible degree as effectively and as efficiently as possible. You do crack that combination through your surgery center vehicle, which I get and I do appreciate, but that's only part of the equation. You've got to get on the professional side of things, you've got to have a business model that addresses that concern. A big concern that a payer also has is that they look around at maybe your practice, and they may not view your practice as adequate or sufficient because it's not large enough, doesn't have enough scale, and it may be something they're concerned about is going to be sustainable. So I think that's part of what you have to contemplate. I'd love to hear comments from our panel. Tom, you want to bite on that?
I think the physician shortage piece is only part of it. I mean, we also have challenges in our efficiencies in the office. How many of your doctors in the group have been struggling with EMR? I bet if you really watch the efficiencies that have been lost with some of these new programs, it's not that there are more patients, it's that we're seeing them in a less efficient manner. I think surgical capacity can be increased. We could start operating more, at least in our center, on days we're not utilizing, even later hours, even perhaps on strange days that would be considered sacrilegious. I mean, a weekend day. And so I think I'm not saying that we're there right now, but it is in fact a problem that I've thought about too. When we have a real overabundance of patients, the physician extenders come in. We're not real good in our field at making use of PAs, nurse practitioners. The ODs are sort of our go-to extenders, but they in fact will definitely enhance our practice in the future, no doubt. Right now we have 3 employed in our group with another at our laser center. We're looking at hiring 2 more immediately.
As the lone PA on the panel, I can certainly address that issue as well. Yeah, I think dermatology has done a really good job of utilizing PAs in their practices. And I know of dermatology practices that have 5 and 6 and 7 PAs who do the treatments, who see the patients, who take call, who can do the biopsies and injections and all that sort of thing. If we don't embrace, I think, the PAs and nurse practitioners in ophthalmology, I think we're not answering the need, and the need is definitely there.
Just to use the follow-up on the dermatology example, about 75% of all derm practices in the U.S. employ PAs and nurse practitioners. We maintain an active database of financial benchmarks in dermatology. The average PA, just to put a financial spin on this, the average PA in our database brings in around $500,000 to $600,000 a year in revenue. And the average cost to a PA, to a practice, fully burdened, salary, benefits, payroll taxes, is about $135 to $150. So you can see at the margin, even it's a reasonable scenario. It's not quite the same in ophthalmology. I get that, but I just think the idea is a really good idea.
Bruce,
So,
do you
Maria?
think we are using the optometrist the same way we would use a PA?
In some ways, yes.
And for about the same amount of money?
About the same amount of money, but truthfully, if I do the same database assessment of optometry and ophthalmology, the numbers are not quite as attractive as they are. Now, granted, it's different, and the optometrists are used in many ways to extend, so they may not necessarily be full-time clinicians generating revenue, but the average optometrist generates about $300,000 plus or minus in professional fee income, and take out between 125 and 150 fully burdened. So the financial model isn't quite as good as it needs to. Now, this goes back to best practices. If I went into our database and just extracted from the 75th to the 98th percentile, for example, in our ophthalmology database, I see ODs consistently in that part of our database generating between $550,000, $650,000, $700,000 a year in revenue, and their cost is about the same, about $150,000. And so that financial model looks quite attractive. I want to know, what do they do? How do they do it? Because that's attractive to me. Well, they provide them support. They hire right. They train them right. There's all kinds of elements to that. But I do agree that's how we have used optometry. But I think just the idea of the PA, I think, is an interesting one that is worthy of discussion. I see Kevin sitting over there who's had opinions about PAs as well. So
the one thing that optometrists cannot do, they can extend certainly in the office, but they cannot extend and assist in the operating room. And I spend a fair amount of my time in the operating room assisting on retina cases, plastics cases, glaucoma cases, wherever they need me. And you won't find an optometrist who's licensed to be able to do that.
Yeah. We had a question over here first, and then I'll take this gentleman's question next.
One of the big challenges I foresee in 2016 is a shift to high deductible plans, and I know that has impact on both the practice side as well as the ASC. Counterintuitively, it may actually be an opportunity to upsell premium services simply because the patients are already going to have to pay more out of pocket anyway.
Brilliant.
Do you
I
think
agree.
that that's
I agree.
true? Okay.
Yeah, and it's not even, I think we've already seen that shift, by the way. I held out forever. I was never going to sell out to the HDHP, the high deductible health plan. But we had no choice. So we've been there, and we supplement that with our HSA, and we're saving a little bit of money and helping those that kind of got caught in that little donut hole. But it was the right thing to do for the company. I see that happening across a lot of our practices. Just by a show of hands, how many of our practices here now provide high deductible health plans for staff? Yep. See, there's your number. It's significant, but I think that's a brilliant idea. I hadn't thought about it, but I like it. Any comments from the panel on that? Do you agree that that's...
I actually want to make one comment on that. As a surgery center, since the beginning, we've been collecting all deductibles and copays up front. And that has really been huge, especially as the high deductible plans are becoming more prevalent. And it actually is an opportunity not only to sell premium products on the physician side, which then also translates into more cash in the surgery center, but it's also an opportunity, because patients are now shopping a little bit, to advocate for price transparency. And it has been a fantastic thing in our market. People are understanding that we offer the same service for a lot less, and they're starting to question why their doctors are taking them to the hospital. So it's an opportunity in marketing and price transparency as well.
Yeah, so I do want to come back to your comment. So I think you're onto something, which is I have an HSA, and company funds a portion, and then my wife and I choose to contribute to the HSA up to the maximum limitation. And having that credit card, I'm more apt to use it for things such as what you're describing. So I actually think that has a lot of merit. So HSAs being health savings accounts, which are generally in tandem with your high deductible health plan. So any other comments from our panel on that question?
I would just say, Stephanie, what she said in terms of collect your copays ahead of time is huge. We saw a real slip in our AR, and then we started researching it and doing that ahead of time, so we got it down to 5% over 90 days. It's huge.
Fantastic. So we had a question right here.
Well, he already started to do it pretty much. I was going to ask Mr. Nelson to tick off sort of the list of things that PAs do in your surgery center.
All right, so the question for Bob Nelson was to tick off kind of the list of what the PAs are doing in the surgery center. Bob started on that, but maybe could fill in a little bit more, add more color.
Well, my primary responsibility is to run the business every day. But I am a PA. I've been a PA for 38 years, and I've worked in all specialties of surgery. And the doctors have recognized that there's a talent that they can avail themselves of. And over the years, their request of my time has really expanded to the point where I'm in the operating room 3, 4, 5 days a week. Not for the full day, but certainly for isolated cases. But I do assist, as I said, on specialty cases. And not every case will reimburse a PA. Patients often, if they're self-pay patients, will factor in a fee for the PA for my assistance. But I'm involved in a lot of specialty cases, as I've said, which frees up the surgeon. They're happy to have an extra set of hands, and it doesn't mean dragging somebody from the office over to the operating room.
Can you run the femto?
I could. I don't right now because I don't have time, but I could, yes.
How, for all your surgeons, how many PAs are there at the center?
There are 2 PAs credentialed at the center. Our center is a freestanding center, so we're not affiliated with any one particular practice, but there are 2 PAs on staff, myself being one of them. And the demand for our time, we really could use another PA to cover the demand for our time.
Ralph?
I'm going to circle back to, why is it okay that a hospital can be on both sides of the playing field when we are restricted by stark regulations? Is there anybody speaking out to hospitals selling their own insurance plans and competing in that marketplace?
So the question has to do with why are hospitals actually able to play both sides of the payer and provider game? Physicians are. They're allowed to do the same. There are a lot of physician-owned health plans, and there are a lot of physicians that have become extremely wealthy building health plans and selling them to United Healthcare. So there's nothing to prevent you from, you need a license, you need to meet capital requirements, and you've got to build infrastructure, and you've got to have a panel, you have to have a network. But physicians have done that for years in different markets, so there's really no restriction on that particular issue. I don't know, Mike is not in the room, but I would have him maybe weigh in on the legal. You sleeping, Romansky?
No, I'm here. I was wondering, nobody's ever asked me for something purely legal like that. Certainly.
Well, we know better, but I thought I'd humor you for at least a minute, wake you up.
No, I think your point is well taken. There's nothing to forbid that type of integration at all. I mean, I don't know the facts about this, but I think that you mentioned there are physicians that are setting these up, and they're more interested in the profit of possibly selling out than the hospital is, because the hospital is just trying to keep the doctors in the system.
It's a strategy for the health system, right?
Exactly.
For the many physicians, it may be a little bit more opportunistic, which is nothing wrong with.
Right.
But there are a lot of large, Ralph, there are a lot of large multidisciplinary physician groups around the country. Some of them are fully integrated, meaning all under the same tax ID number. Some of them are what I'll call a network model. But all of them are using that large scale to contract with health plans. Many of them have also decided to create their own plans and market and sell their own plans. I think what's instructive for us ophthalmologically is how do we do that potentially as a strategy to try and become more relevant? So there is a fair amount of activity I'm hearing about. So I'm going to be very interested when Lee comes back in a year or two to understand now how that group of 17 independent physicians, maybe there's 2 in one group or 2 in 2 groups, whatever, take it to the next step of organizing themselves on the professional side, short of merging, so that they can have a voice at the table professionally. It's great that they have a relationship with the health system, because what that's done is it's kind of insulated them for any and all contracts that health system controls. That surgery center is going to be on every single one of those contracts on the facility side. But they're going to have to think about, because today every one of those 17 practices has individual provider contracts with a whole host of plans. And that works okay. That works okay so long as you have access. But if a competitor comes along with a product that has all of the ODs, MDs, and is willing to take and share risk and goes to that same health system, you could find yourself saying, now, how are we not on that, but we have that? And that is the crazy part. That's the cross currents I alluded to. It's complicated. So you're going to evolve, and I think that's the issue. In each market, what I hear is you're going to evolve because you're resourceful, but don't bury your head saying, we got this covered, we're fine. Not to the gentleman's point, is your model sustainable 5, 10, 15 years from now? Probably not. But it's not like tomorrow you got to fix that problem, but you better be anticipating that and figuring out that model, in which case you need to figure out how to kind of assemble or amalgamate to become more relevant in the future, if you even care. You might say, well, I got 5 years to go and I'm riding out the wave, and then who cares? I get that. Totally get that. But if you want to see it perpetuate, you want to see it grow, then you got to think a little differently. Lee?
Yeah, I was just going to add some color to that, because our group has sort of seen that. And for instance, we're looking at potentially creating an optical lab and, coalescing around, because we all have optical shops in our offices. They're all adequately run. We certainly could all do better. So things of, those sorts of big ideas.
Think of things that we would all benefit from that would save us money or deliver better quality. And we don't have to merge necessarily to get that.
Exactly.
Excellent
And
point.
the OD, and it's interesting, the whole OD discussion, where we see that as an issue too. So what we are trying to do is we've convinced the health system that, we're going to be your network, but we want to bring in the ODs under us. So we've gone to them with this thought. So now the health system does see the optometric network as valuable, but I would like to believe that we've educated them to kind of how this should work, and we'll see. But that's sort of what's kind of playing out right now.
Let me stay on the education theme, because I thought Mike raised the issue of having the congressman. It sounds like to me, Tom and Steph, you guys have had payer representatives come to your facility. And now what Lee is saying is all about education. You are the experts in your field. That's their perception. Act the part. Take the time to educate them about how eye care really works. What the difference is, God forbid, between an optometrist and an ophthalmologist. This is a CFO in a hospital, health system, or health plan, and they don't know. So you bring them to your facility, you do a little professionally done dog and pony show, you show them a surgery, and that's how you build relationships. And in the end, just like you can all remember who mentored you, right? Who made a difference in your life? I met with a doctor this morning, and he was talking about a preceptor, someone that mentored them, made a big difference in their life. The same thing is true here. If you take the time to be the one to educate them, they will not forget that. They will not forget that. But you can't use that as a lever against them. You have to be prepared to kind of work with them, right? Any other comments on that? Questions? Any more questions? We're kind of down to our witching hour here in about a minute. Going once? Going twice? We have a taker.
We talked a lot about the differences in payment between ASCs versus HOPDs. I'm wondering, since Lee's Surgery Center is 20% owned by a hospital, does the surgery center bill as an HOPD, or does it bill with ASC fees? Is that a strategy?
Yeah, go ahead, Lee.
It's a great question, and it's relevant because of the next level of equity we're planning to sell our hospital. So currently, at a 20% share, they can't bill at an HOPD rate. But what's interesting is this hospital system has, I believe, genuinely seen the light that the HOPD rates are going to go away. And so they're being aggressive about moving their surgeries out of their hospitals into ambulatory surgery centers, partnering with the physicians, even though they're getting the ASC rate, not the HOPD rate. And they've done it across the board. For us, as I said, for the GI center, for a multiple specialty center, they've really, I think that they see what's coming too. And so we're kind of at the bottom. We're there. We have a center. We're operating wonderfully. Bring your cases here. At some point, your center is going to go away. And so I think that in our community anyway, I think the hospital has seen that.
Well, I'd like to wrap things up. And first of all, I'd like to thank our panel members for doing a fantastic job. These are people that genuinely care, and they were great to work with. And we had no idea what we were going to do, but said, just relax, we'll have some fun. And I hope that you found that conversation helpful. I want to finish just by going back to, and mine are not inappropriate, Mike, just so you know, my final comments, just to qualify that. I don't have to do a survey. But I do want to actually come back in all seriousness to something Mike did say, which is hard for me to do. And that is that the argument that Mike made related to in-office cataract surgery and the focus after the 10-minute little wine session, cheese and wine session, that the focus came back to the patient. The asset that you have is what is best for the patient who are beneficiaries or members of those health plans. That's your argument always. Always. It's best for your patient to have that procedure done in your ASC. That is not a difficult argument to make, but you've got to make it. You've got to advocate for the patient. It's better from a quality standpoint, inclusive of the patient's experience. It's better from a cost and value standpoint. And lastly, remember, what may be a source of revenue for you from a health plan is a cost for them. Think about that. It's a cost for them. Why wouldn't they want to do what's best for their patient? And oh, by the way, it's lower cost by a factor of 0.5. It should be a non-issue. But if you're not at the table advocating for the patient, you will become less relevant, truthfully. Not irrelevant, but less relevant. And that is your challenge in this world order, is becoming more relevant. So again, thank you to the panel. One panel member is going to stay, right? Yes. And so thank you again, guys. Appreciate it.